Yes, ma'am. Within 10 seconds, we will be live.
Can I start, Abhishek?
Yes, ma'am. We are live
Yeah.
now. I'm just
Yeah.
sharing the screen.
A very warm welcome to all the esteemed faculty members and the delegates who have joined today with us. This is the Public Awareness Committee Fogsi Zonal Webinar Series, and today we are doing it with the East Zone. I'm very happy to announce that this is the 29th episode of the series, and this is the brainchild of the chairperson, Dr. Priyanka Roy. We will move ahead with the inauguration first, and then I can invite him to introduce our chief guest for today.
असतो मा सद्गमया तमसो मा ज्योतिर्गमया मृत्युर्मामृतं गमया ॐ शान्ति शान्ति शान्तिः.
Thank you, Abhishek. September being the PCOS Awareness Month, the theme for today's webinar is also PCOS, and we have the stalwarts in their respective fields who will be enlightening us for the topics, including oral stimulants. Then Sevanti ma'am will be highlighting the aesthetic aspects, and then we'll be having a case-based panel discussion moderated by Dr. Indrani Roy madam and Dr. Shatabdi. I invite Dr. Priyanka Roy to please formally welcome all the delegates and the faculty members and introduce our chief guest for today, Dr. Bhaskar Pal sir.
Thank you so much, Monica. It indeed gives me pleasure to be, of course, part of this webinar, and it gives me immense pleasure to welcome all of you to this webinar series, the 29th episode of the Public Awareness Committee program. As said by Monica, I would also like to thank and welcome our coordinators, Dr. Monica, Dr. Shatabdi, and Dr. Atalia, who have put in immense work in this webinar, and also our conveners, Dr. Rekha Jha ma'am, as well as Dr. Indranil. This webinar would not have been possible without the blessings of our President, Dr. Jaideep Tang sir, Dr. Madhuri Patel ma'am, our Secretary General, and the VP in charge, Dr. Ajay Mane sir. I am also indeed privileged to have with us Dr. Parikshit Tank also who joins us on and off for the webinars, and Dr. Kalyan has always been there as a support system for all our programs. It is again my pleasure to welcome our chief guest for today, none other than Dr. Bhaskar Pal sir, and the guest of honors, Dr. Alka Pandey ma'am and Dr. Bhagyalakshmi Nayak ma'am. So to welcome first Dr. Bhaskar Pal sir, another senior of ours from Bengal itself. We fondly call him Dada, and he has been recently elected as the president-elect of Fogsi. There has been a lot of effort that has gone in all the work, especially towards the endoscopy committee, towards AICC, RCOG, etc. Recently, they're doing the RCOG program as well in Calcutta in the next couple of days. He has been the chair of the AICC RCOG from 2021.
It's okay. Please don't introduce.
Sure. So I welcome you, sir, and requesting you to kindly say a few words. And once again, we, on behalf of the PSC, congratulate you for taking over as the president-elect of Foxy.
Thank you, Priyankur. No, we are actually on the first day of the RCOG conference in Calcutta, and I'm there. And at the outset, I want to thank Priyankur and the powerhouse of the PSC committee, Dr. Monica, and also Dr. Shatabdi and Dr. Athilla for inviting me to be the chief guest. I also, it's a pleasure meeting so many friends, Rekha Jha madam from Bhagalpur and Indranil Datta from Kallani, who are the conveners for this program, and my co-guests for today, Alka Pandey madam and Bhagyalakshmi. We have PCOS is something where the debate never ends and our learning never ends. So we have a fantastic program with Dr. Sujata Kar, a doyen in the field of infertility, speaking on oral ovulations in PCOS. Dr. Shebanti Goswami from Bengal speaking on aesthetic aspects of PCOS, and Dr. Indrani Roy and Dr. Shatabdi Dey moderating a panel on case discussions on PCOS across all age spectrum. It's a pleasure to have my so many dear friends and seniors, Dr. Maushami De Banerjee from Bengal, immediate past president of Bengal Society, Dr. Ritunath Diokata, my senior president of Gangtok Society, Hafizur Rahman, secretary of Gangtok Society, Dr. Amitabh Pal from Bardhaman Society. Here as chairpersons, my dear friend Dr. Meena Samant as the expert, and expert panelists Dr. Nidhi, Dr. Sweta, Dr. Esha, Dr. Gayatri, Dr. Simi, Dr. Paulami, Dr. Bandana, Dr. Meganko, and Dr. Sharda. So I hope this will be a very fruitful meeting. And please keep up the good work. I think the PSC committee has been excellent under Priyanku's tenure as well as in Kalyan's tenure. And I think the most important about committees is continuity. And I think the continuity helps a lot in going forward. So the new chairperson can immediately hit the ground running the moment they get elected. So I hope that continues. And again, I will end by thanking all of you across the country for electing me as president of Fogsi for 2026. Thank you very much for inviting me.
Thank you so much, Bhaskar sir. That was indeed a pleasure to have you with us. That shows your commitment. In spite of being in a conference, you were here as the chief guest. Thank you, sir, for your warm words. I now hand over to Monica to kindly take it forward, introduce the guest of honors, and please go on. Thank you, Monica.
Thank you, Bhaskar sir, for gracing the occasion, and thank you, Dr. Priyankur, for your words of welcome. Dr. Alka madam is busy in an obstetric emergency, and Bhagya Lakshmi madam will join in the next 5 to 10 minutes. We will move ahead with the academic session for the first talk is by Dr. Sujata Kar madam. Abhishek, can we have the slides for the chairpersons? Yeah. The first chairperson for today's session is Dr. Maushami Banerjee madam. She is a consultant obstetrician and gynecologist at Kolkata, currently the president of the Bengal OBGYN Society. She has also been the organizing chairperson of Fetovision 24, BOSQ 47, Endogyne 24, and Wisdom 24. She is a vice president of IMA Calcutta branch. We welcome you, ma'am, for chairing this session. And our next chairperson, Dr. Ritunath sir, is a principal consultant at STNM Hospital, Gangtok, Sikkim. Maushami madam, I request you to please introduce our speaker, Dr. Sujata Kar madam. As she is traveling, the network quality is not very good, so she has sent us a recorded talk of hers for today. So if you could please kindly introduce her so that Abhishek can play the recording now.
Yes. At the beginning, I must thank the Fogsi office bearers at the that is Dr. Jaideep Tank as president, then Dr. Madhuri Patel, then Dr. Parikit Tank, then the VP in charge, Dr. Ajay Mane, the chairperson, Dr. Priyanku Roy, and Dr. Kalyan Barmade, and obviously the coordinators. Thank you, Dr. Manika and Dr. Shatabdi and Dr. Atulya, and the convener, Dr. Rekha Jha and Indranil Dottu, for giving me the opportunity to be a part of this wonderful program of the Public Awareness Committee of Fogsi in association with the East Zone episode 29 of Sujata Kaur. The present designation is practicing gynecologic endoscopy and assisted reproduction for last 27 years. Her area of interest on polycystic ovary syndrome, proteomics of male infertility, scope of stem cells and gynecology. The major achievements and honors, that is the best graduate and 7 gold medals in MBBS MD, credited with the first IVF baby of Mr. Nurissa, first TSA frozen embryo and laser baby award. And then she has got a number of publications, 15 original publications related to PCOS and male infertility, and many chapters in national and international journals. And the position is the Honorary General Secretary of ISAR India, Executive RF, PCOS Society, and FPS of India. So Over to you, madam, with your topic, oral ovulogens for ovulation in induction, which is best for PCOS and why?
Good evening and greetings from Bhubaneswar. Thanks to Foxy for giving me this opportunity. My topic today is oral ovulogens for ovulation induction, which is best for PCOS women and why. Now, all of us are aware that 600 to 650 oocytes undergo atresia every month for one single oocyte to be selected dominant and to ovulate. Now, this is what happens in normal physiology, but in PCOS, there is a chronic persistent state of anovulation where all the gonadotrophins and sex steroids are in a steady state. We do not see the normal dance of the gonadotrophins and sex steroids as we know in the normal menstrual cycle. And now we know that anti-Mullerian hormone is intricately associated or is responsible for this disordered folliculogenesis of PCOS. In today's meeting, I will not I'll not have the time to go into the details of this, but to give you an overview, AMH and PCOS are intricately related in pathophysiology. Serum levels are 2 to 3-fold higher in PCOS women and 5-fold higher in follicular fluid of PCOS women. It is consistent with increased antral follicles of polycystic ovarian morphology. Apart from number of follicles being more and therefore AMH being more, it is also very much possible that each follicle secretes more AMH than normal. Some studies have reported as high as 75-fold higher per follicle compared to a normal ovulatory women. So AMH will certainly has a role in pathogenesis, and not only AMH is a marker of polycystic ovarian morphology. Now PCOS women, we know that ovarian stimulation or ovulation induction is a challenge. It's almost like walking a thin rope between too much or too less. So ovulation induction certainly is a challenge. Today we are going to talk about oral ovulogens, which are pharmaceutical agents that initiate, augment, modulate hormonal and gametogenic response so as to result in the development of a dominant follicle and thereby get ovulation in the cycle that you do ovarian stimulation. So usually using oral ovulogens results in a mild form of stimulation. Oral ovulogens can be used in chronic anovulation like in PCOS, which are the vast majority of cases, maybe about 80% of cases. You can use them for mild ovulation in normal responders in whom you are doing IUI, or it can also be used in mild stimulation protocols of IVF. The aim, of course, is to optimize the selection of the drug for best protocol and lowest risk. Now, what are the oral ovulogens? They are usually anti-estrogen, aromatase inhibitors, clomiphene citrate, tamoxifen, raloxifene, and letrozole or anastrozole. Now, let us have a look at how mechanism of action of each of these oral ovulogens. The clomiphene has been in use now for almost 50 years. And it's very easy, it's well known, it's been used for a very long time. It has minimal side effects. Dose flexibility is there. You can start from day 2 or up to day 5. You can start. It has 2 stereoisomers, ZU and N-clomiphene in various percentage in this ratio. Tamoxifen, raloxifene is not as commonly used as clomiphene citrate, but yes, there are situations where you use them. Anti-estrogenic, it is an anti-estrogen with weak estrogenic activity, and these primarily act on the HPO axis. Now, clomiphene citrate, you will all agree that apart from use of clomiphene citrate, which has been tremendous over so many years, abuse of clomiphene citrate also has been rampant amongst gynecologists. Clomiphene citrate induces gonadotropin release from the pituitary gland by binding to the estrogen receptors in the hypothalamus, blocks the negative feedback of estrogen, leads to increased and prolonged FSH-LH secretion. It is weak and prevalent anti-estrogenic effect on sensitive tissues like endometrium and ovaries also. Now, ovulation rate with clomiphene is very good, about 70 to 80, 85%. Pregnancy rates are 30 to 40%. Miscarriage rates are, almost up to 20, 25%. Multiple pregnancy rates are high, stands at 8%, and single live birth rate is about 25%. And in a large number of patients, we also see clomiphene citrate resistance. So the key points are it's centrally acting, therefore can result in multiple follicles and therefore theoretical risk of OHSS. It has an adverse effect on endometrium and cervical mucosa. It has a long half-life and slow clearance from the blood, and discrepancy between ovulation rate and pregnancy rate and live birth rate. Now, the current recommendations for clomiphene citrate is that it should be maximum one should limit a patient's lifetime exposure of clomiphene citrate to about 12 treatment cycles. Tamoxifen also is a SOM used about 20 milligrams from day 2 or day 3. I think the best situation where you may use tamoxifen instead of clomiphene citrate would be as an alternative to CC if the CC is not responding, or if there is inadequate endometrial thickness with clomiphene citrate. But now for vast majority of situation, letrozole has taken over. Letrozole is an aromatase inhibitor. It results in an acute hypoestrogenic state. It releases the ovary from the HBO negative estrogen feedback. Advantages of letrozole are many. It has a short half-life, acts on the ovary, no negative side effects on endometrium and cervical mucus, and usually results in a monofollicular ovulation because it does not result in sustained increase in the FSH levels. Optimal dose developing studies were never done for letrozole. Based on current data, the optimal dose is probably 2.5 to 5 milligrams. A higher dose can be used. It is very well tolerated with very less side effects. Now, if we have to choose between clomiphene citrate and letrozole, can we make the right choice? I think for vast majority of us, it has become a fact that we use letrozole as a first choice. But is it also supported by evidence? Yes, it is supported. I also published a randomized controlled trial comparing the two. But major 4 publications were the iconic one, multicentric trial, a large trial from Richard Legro's group, which showed very clearly that ovulation rate, the live birth rate, clinical pregnancy rate were all higher with letrozole compared to clomiphene citrate. The congenital anomaly rate was also shown to be clearly lower in letrozole group. And the best part was that when in the group analysis, letrozole was better than clomiphene in all BMI groups, low BMI as well as higher BMI. And after that, many meta-analysis and systematic reviews and IPDs were published. I was part of them. 2 of the major publications that showed clearly that letrozole is a better drug. And of course, the new international guidelines also tell us that letrozole is probably the first-line ovulation induction drug. And this was another publication in Human Reproduction Update in which I was a co-author, in which it was shown that probably we should personalize our approach. Letrozole may be as good as clomiphene citrate plus metformin, or rather clomiphene plus metformin may be as good as letrozole alone in certain group of patients, especially women who have high testosterone or more androgenic. For them, letrozole might be better. But those who are more hyper insulinemic or insulin resistance is higher, they might be better with clomiphene plus letrozole. And therefore, at least for our situation, we must think that clomiphene plus letrozole also is a good, clomiphene plus metformin is a very good choice for us. Gradually, as we've started using more and more letrozole, we've started to also understand that many women are resistant to letrozole. And now with studies have shown that women who have very high AMH levels, they are probably almost always resistant to all oral ovulogens and certainly also to letrozole. So women who are obese, hyperandrogenic, and who have very high AMH levels and very high ovarian volume, they are probably going to be resistant to letrozole. And so therefore, many other protocols for letrozole use has come up to use letrozole in a manner that can, if this conventional dose of 2.5 or 5 for 5 days fails, there are people have advocated a prolonged 10-day letrozole protocol, or one can increase the dose to 7.5. One can use a stair-step protocol by using 2.5, 5, 7.5, and 10, etc. So many other protocols have also come in, which can be used if the conventional dose of letrozole fails. Now, no discussion on oral ovulogens will be complete unless we discuss the role of insulin sensitizing agents. So what is their role? Yes, certainly many years have passed since metformin has been there, and metformin is now a very solid part of our prescription for PCOS women for ovulation induction, especially in Asian Indian women who have very high body fat, very high visceral fat, and very high insulin resistance. And it has also been shown in literature that yes, clomiphene citrate with metformin or letrozole with metformin is a very good option where you are expecting letrozole resistance or clomiphene resistance. So the key takeaways from my talk today is, as expected, all PCOS women have different phenotypes and genotypes. Pre-ovulation induction assessment of PCOS phenotype and metabolic disorders is very much necessary if we have to do ovulation induction, which means all PCOS women before ovulation induction, we must check their metabolic profile also, which means fasting blood sugar, postprandial glucose challenge test, then lipid profile, their BMI, presence, absence of acanthosis, etc. We should be checking vitamin D levels, etc. can be done to look at their metabolic, what is their metabolic phenotype. So letrozole is certainly the first line ovulation induction drug, apart from the fact that we are not talking about lifestyle changes, which is the first time. But today's discussion is only about oral ovulagens. So letrozole, clomiphene plus metformin also may be as good as letrozole in select cases, and especially in our scenario, it might be a very good choice. Letrozole plus metformin is also an excellent choice where needed, although we do not have too many publications in this combination. We have many publications with showing clomiphene citrate alone or clomiphene citrate plus metformin, but we do not have too many publications with metformin. Letrozole can be prescribed in various regimens, like I showed you, if it is resistant to the conventional dosage. Metformin has excellent data to support. Now, current data also is coming out to show that metformin dosage can be titrated according to the BMI. But then women who are not necessarily glucose intolerant also should be prescribed metformin to improve their chances for ovulation induction. Inositols, again, are very much there in the market, and very much being prescribed. But again, it is comes in the category of a nutraceutical. It is available off-label in a free market. Anybody can buy it. It certainly has benefits and improves the metabolic parameters in cases of PCOS women. But how far it is effective in improving the reproductive outcome, along with other oral ovulagens, we still have lack of data supporting inositol, and their metformin would definitely come in first. where ovulation induction is concerned. And also inositols are expensive compared to metformin, but the biggest advantage of inositols are that they're very well tolerated. And patients very often have already started it on their own as a nutraceutical, as a nutritional supplement, if they know that they have PCOS. So that is about oral ovulogens and what are best and how we can use them in cases of PCOS for ovulation induction. Thank you so much for your kind attention.
Thank you, Sujata ma'am. Maushmi ma'am, over to you for your expert comments, ma'am.
Yeah, thank you, Dr. Sujata, for wonderfully presenting this and going to all the nooks and corners, and all our dilemmas about these drugs are very well cleared. Is there any question from the floor? What do you think, ma'am, your treatment or your comment about the lean PCOS with with this problem?
Ma'am, I think Sujata ma'am is not online right now. She has sent it a recorded lecture, ma'am. So we've played the recording, ma'am.
Okay.
Yes, ma'am.
Okay, thank you, everybody. It was a wonderful program. And thanking once again for giving me the opportunity to be a part of this. Thank you.
Thank you, ma'am. Thank you for joining in spite of being in the RCOG conference. Thank you so much. I can see Alka ma'am and Bhagyalakshmi ma'am have joined. So Abhishek, can we have their CVs, please? Good evening, Alka ma'am.
Good evening, Monica. So I think you know very well now. I was the past vice president
Yes, ma'am.
and retired professor.
Ma'am, you have been in charge
Patna
of
Medical
Public
College.
Awareness Committee.
And yes, and member of ICOG Governing Council, and also Jogi corresponding editor. But that is, I think, more than enough. And her lecture was superb. No aspect was untouched. So it was a wonderful program, Monica.
Ma'am, and for your blessings, ma'am.
Yes, and you are doing so hard work now. I really wish you all the best for your future endeavors.
Thank you so much, ma'am.
Yes. Okay.
Thank you,
so much
ma'am.
for giving me and for remembering me also. Okay.
Ma'am, it is always an honor to have you with us on board for all Public Awareness Committee activities. Thank you so much for joining us and giving your blessings, ma'am.
Thank you so much. Okay.
Thank you.
Bye.
We also have Bhagyalakshmi ma'am, who is also the guest of honor for today. She is the head of the Department of Gynae Oncology at AHPIC, Cuttack. She has been the chairperson of the Oncology Committee, Fogsi, from 2018 to 21, and she is the governing council member of ICOG. We welcome you, ma'am, for your blessings for this webinar.
Yeah, thank you so much, Monica. I think I was really held up with some meeting with my director. So I think this is a beautiful program, but and both the speakers are so close to me, Dr. Sujata Kar and Dr. Sevanti, who I am going to, I heard Dr. Sujata's lecture and we'll see again, go to hear also Dr. Sevanti's lecture. And the best thing is the panel, that's the all woman panel. So I think that will be a real good thing that I really love people, women power. And Monica, I have no words for you. You have been working so hard. And Dr. Priyankur is a brother to me, and Dr. Bhaskar, both of them. And I wish all the best for all your endeavors for this public awareness. And you are doing so excellent work, Public Awareness Committee, and all the best wishes for this webinar. And I'll be throughout the webinar. Thank you so much. Thank you so much, Monica. Please go ahead with the next talk.
Thank you, ma'am. Thank you so much for your blessings. It is an honor to have you on board with us today. We now move forward for the next academic session. It's a talk by Dr. Sevanti Goswami, ma'am. Can we have the CVs of the chairpersons, Dr. Amitava Pal, sir? Abhishek, the CV slides, yeah. Our first chairperson for today, Dr. Amitava Pal sir, is the founder secretary of Bardhaman OBGY Society. He has been the organizing secretary of Fogsi E-Zone in 2016 and the Milan Conference in West Bengal in 2022. He has received the Foxy Achiever Award in 2023 and he has many publications to his credit. We welcome you, sir, as a chairperson for this session. Our next chairperson is Dr. Hafizur, sir. He is a professor in obstetrics and gynecology and a part of the governing council member of ICOG. He is also the head of the department of AIMS Kalyani and unit chief of SMIS and SMU Gangtok. He is the founder and current secretary of the Gangtok OBGY Society. With more than 65 scientific research publications to his credit, he is also a peer reviewer of more than a dozen international journals. We welcome you, sir, and it is an honor to have you with us. I request Amitava, sir, to please introduce Dr. Sebanti Goswami, madam.
Oh, am I audible? Hello?
Yes, sir. Yes, sir.
So first of all, it is a very great pleasure to me by the Public Awareness Committee of Foxy for giving me opportunity as a chairperson of a renowned speaker, Dr. Sebanti Goswami, who is very well known to me and she is my friend. And I am also giving thanks to Chief Guest Dr. Bhaskar Pal, Guest of Honor Dr. Alka Pandey and Dr. Bhagyalakshmi Nayak. So Dr. Sebanti, so we are waiting eagerly for your speech. And she is consultant gynecologist Kolkata, former associate professor of Medical College Kolkata, and she has 45 publications in national and international journals, chairperson of Quiz Committee Foxy 2018 to 20, honorary treasurer of BOGS, that is Bengal Obstetrics and Gynecological Society. She has special interest in vaginal surgery and cosmetic gynecology. Dr. Sebanti Goswami, we are eagerly waiting for your, and the dash is yours.
Thank you. Thank you. Can I share my slides?
Yes, ma'am.
Are my slides visible? Are my slides visible?
Yes, yes.
It's a black screen now. Yes, ma'am.
Yes.
Visible. Perfect.
Yeah. Okay. So good evening to everybody out there. At the onset, I thank Dr. Monica for involving me in this program. I thank the chairpersons, Dr. Pal and Dr. Hafizur Rahman, for a kind introduction. And I thank the PAC Committee Foxy for choosing me for this program. And it was really nice to see Dr. Alka and Dr. Bhagyalakshmi on board with us. Now, today we are talking about nothing but PCOS, which I say is almost become an epidemic in gynecology. If we see 10 patients one day in our chamber, then we see that at least 2 to 3 of them would be having PCOS. I think all the gynecologists out there would agree with me. But whenever we talk about PCOS, it's the most common endocrine disorder, and estimated prevalence is about 6 to 10% of the women, particularly of the reproductive age group. Whenever we talk about PCOS, the thing which comes to our mind first is obviously irregular cycles, or which are obviously due to anovulation, subfertility. These are the main problems with which the women come to us. But we tend to forget a very important aspect of polycystic ovarian syndrome or the metabolic syndrome, that is the features of androgen excess, which actually become lot of aesthetic concern to the patients. And as if we refer to the Rotterdam criteria of diagnosis of PCOS, we know that androgen excess, which is manifested by either clinical features or of hyperandrogenism or evidence of hyperandrogenemia in biochemical aspect, it's one of the diagnostic criteria of PCOS. And it is the androgen excess which actually is responsible for the aesthetic aspects or aesthetic concerns of a patient with PCOS. Now, what are these aesthetic concerns? We all know that there are mainly 4 things which actually hamper the cosmetic appearance of the patient with PCOS. First is hirsutism. Second is acne. The third is an androgenic alopecia. And the fourth is the dark skin in the neck, which has acanthosis. Now, let us take on the different aspects of aesthetic concern one by one and discuss them. First is hirsutism. increase in the terminal hair more than vellus hair in the androgen-dependent areas of the body. It has been found that in the general population as a 5 to 10% of women might have excess of hair. That might not be hirsutism. Hirsutism is increase in the terminal hair in the androgen-dependent areas of the body. And secondly, PCOS is the most common cause of hirsutism. About 57 to 82% of the patients who are having the PCOS have some sort of grade hirsutism or the other. Why is this? We all know by now that it's a hyperinsulinemia, which is at the crux of the matter, an increase in the insulin-like growth factors, which results in hyperandrogenism. And hyperinsulinemia increases the activity of the 5-alpha reductase enzyme. Now, what is this enzyme? It is the one which converts testosterone into the more active form, that is the dihydrotestosterone or DHT. And the moment there is increase in the 5-alpha reductase activity, there is more amount of the active form of testosterone, that is the dihydrotestosterone. Therefore, there is a dysregulation of the growth of the hair follicle. And there is increased transition from the vellus to the terminal hairs. So androgen bioactivity basically is regulated in the hair follicle, primarily by the conversion of testosterone to dihydrotestosterone. And the enzyme at the crux of the matter is 5-alpha reductase. So androgen excess leads to increased size of the hair follicle, that increases the diameter of the hair, and proportion of the time the hair remains in the anagen phase. As we all know that there are 3 phases of the hair. Now here, the anagen phase or the growth phase of the hair is increased because of the increase in the level of 5-alpha reductase and because of the increase in the activity of the insulin. So if more and more hair will be in the anagen phase, there will be more and more amount of the terminal hair remaining in the patient. So how do we evaluate? We ask about histories first. We asked about the rapidity of progression, whether it had a very early onset, whether it is intensely over the body, or whether it is progressing very quickly. Because hirsutism itself does not mean always PCOS. If a woman says that a hirsutism is rapidly progressing, it's very intense, then we have also to rule out the androgen producing tumor of the ovary or adrenal, or even late onset CAH, congenital adrenal hyperplasia. Ask her about menstrual history. That would more indicate about PCOS. And if she is taking any medication which actually might cause hirsutism, like phenytoin, like cyclosporin, etc. And we know that there is a very good score, which is known as the Ferryman-Galloway score. And nowadays we use the modified Ferryman-Galloway score for scoring the level of hirsutism in women. There are 9 areas which are evaluated, and there are 4 scores which are kept, 0 to 4. 0 means there will be no hair, and 4 means there will be dense hair. And a total score of greater than 8 actually is reflected as objective hirsutism. But there's a disadvantage of this Ferryman-Galloway score. It might have an inter-observer variation because it has got a score from 0 to 4. What might seem 1 to some might seem 2 to another observer. So it might have an inter-observer variation. And secondly, many of these Hirschut's women are already using some depilatory or epilatory methods and would come to us at a time when already they might have removed some amount of hair. So prior hair removal might even become a hampering factor in scoring the Ferryman-Galloway score properly. How do we biochemically assess the hirsutism, or is it really necessary? Now, is it really necessary to measure the level of the androgens in each and every patient of PCOS? The answer is obviously no. But is it necessary to measure the level of the testosterone or other androgens in a woman with hirsutism? Here, the different societies have got different opinion. The Endocrine Society of the World, it says no, but the Androgen Excess Society, which is again a society which deals only with androgen excess, they say that if a patient presents with hirsutism, it's always the better to go for an estimation of the androgens. Now, which one should we measure? Now, total testosterone is better to measure always than free testosterone. Although it might seem that measurement of free testosterone would have been better because that is the more active form of testosterone. But whatever standard biochemical assays we have in our hand, there, the quality of the tests which are available for free testosterone are not very specific ones. So it's always better to go for the total testosterone. Then again, there is a problem here. We have seen many Hirschut patients who have got very overt Hirschutism, but when we go for the determination of the testosterone level, we see that the testosterone level is either very close to normal or it is just above normal. It is much below 150 nanogram per TL. That is why it has been found that the clinical phenotype of the patient of PCOS might not be synchronized with the hormonal milieu of the patient. A patient might be having normal or slightly raised testosterone, yet the patient might be having a great amount of Hirschutism or a very higher Galvez score. This is because of the level of the 5-alpha reductase activity at the hair follicle, and also because of the action of the testosterone on the receptor which is available at the hair follicle. Second one which is measured often is DHEAS. Now, dehydroepiandrosterone is a product of the adrenal, and its metabolite, a very stable metabolite, is DHEAS. Now, this is raised more in adrenal problems than in case of PCOS. And if it is more than 700 microgram in a Hirschut woman, then definitely it indicates more of an adrenal tumor than of a PCOS. 17-hydroxyprogesterone is measured to rule out congenital adrenal hyperplasia. If a Hirschut woman's presence, and we need to find out whether it's PCO basically is a diagnosis of exclusion, whether it's due to PCO or whether it's due to CAH, particularly in severely Hirschut women, we should do the 17-hydroxyprogesterone. If it is more than 200, then definitely it indicates more of a congenital adrenal hyperplasia. 24-hour urinary cortisol, that is done if we are suspecting a cortisol excess, because many of the Cushingoid patients also would come with the features of Hirschut's. And lastly, a pelvic USG to support the hyperandrogenism so as to fulfill the Rotterdam criteria. Now, what are the treatments available for this aesthetic concern? We have oral medicines or topical things, and we have the cosmetic treatments. Pharmacotherapy may not completely eliminate the hair growth. This is something which we need to tell the patients before we start them on oral drugs. It may not eliminate the terminally differentiated hair. It might need cosmetic therapies with it in order to remove the hair which is already there. And it is contraindicated for Hirschut women who are seeking pregnancy, because most of them are either oral contraceptives or are teratogen. So what do we have in our basket? Let's see. The first line of treatment, that is the oral drugs for Hirschut's, are oral contraceptive pills. Oral contraceptive pills, by their method of action, they suppress the steroidogenesis of the ovaries and therefore suppress the amount of androgen which is produced by the ovaries. Along with that, the estrogen component of the oral contraceptive pills basically increase the serum, SHBG, hormone binding globulin. So if the SHBG is increased, the amount of free testosterone decreases. So that is how it decreases the total testosterone, as well as by suppressing the ovarian steroidogenesis, as well as the free testosterone by increasing the level of SHBG. But when we choose an OCP for a Hirschut woman, we have to give importance to the progesterone component of the OCP. If the progesterone component of the OCP is an anti-androgen itself, like cyprotenone acetate or drospirenone, that helps even better in reducing the amount of the androgen. So the OCPs are first line of treatment as far as pharmacotherapy is concerned, and an OCP containing cyprotenone acetate or a drospirenone would be better in this respect. Second line of treatment or pharmacotherapy are anti-androgens, like we have spironolactone, flutamide, or finasteride, which are the commonly used ones. Spironolactone, which is actually aldosterone agonist, it acts by inhibiting 5-alpha reductase. And so it prevents the conversion of testosterone to its more active form, dihydrotestosterone. It can be given daily. These drugs are better if they are given as an adjunct to OCPs than given alone. Flutamide is actually an androgen receptor antagonist. But the problem with flutamide is that it is hepatotoxic, and that is why its usage is limited. Finasteride again acts as a inhibitor of the 5-alpha reductase enzyme and prevents the conversion of testosterone to dihydrotestosterone. Both flutamide and finasteride are teratogenic and are contraindicated in a woman who is a Hirschsprung but who is planning for pregnancy. But flutamide is hepatotoxic, finasteride is not. That is how finasteride can take an upper hand over flutamide. Third one is the GnRH agonist, which is rarely used here. But if the patients cannot tolerate OCPs or have contraindications of OCPs, if they have contraindications of antiandrogens, then in those cases, some GnRH agonists have been used in few cases, and there have been randomized trials with that too, but definitely they cannot stand up as the commonly used agents. Locally applicable eflornithine hydrochloride cream is there, which is approved by US FDA. And that actually, this is a cream which acts by inhibiting the ornithine carboxylase enzyme. Now, this ornithine carboxylase enzyme actually is an enzyme which actually mediates a rate limiting step in the polyamine production. So if you can stop a polyamine production, definitely you would stop the formation of the amino acids which are necessary for forming the proteins in the hair. That's how this eflornithine hydrochloride cream acts, but it's always better. All the studies which are available with this cream are mostly with application of this cream along with laser therapy. That helps in getting more satisfactory outcome. And lastly, insulin sensitizing agents, as my last speaker also said, that this have come up as the nutraceuticals. They actually claim for reduction of the levels, but they are expensive. And the evidence, as far as the studies are concerned, are not very robust to use this insulin sensitizing agents as androgens. So they don't come as the first line or second line agents. They can be only adjuncts. Cosmetic therapy can be temporary or permanent. Temporary can be shaving, which is an age-old method, but definitely it's a very temporary method. The outcome is not very satisfactory because it takes away the hair just up to the surface of the skin. And so the hairs come up within 1 to 2 weeks. And this can cause irritation, cuts, bruises, or even pigmentation after repeated shaving. Waxing is used by some women, but this is better for larger areas, not for smaller areas like mustache area or the beard area. It applies a glue-like thing, sticky thing, and when you pull it up, then the hairs come up. These are better for hypertrichosis affecting the limbs, not for the beard or the mustache area. Now, epilation or plucking of the hairs, or as we call threading, is a method in which the hairs are plucked out from their follicle. But the follicle remains. So that is why it is a temporary method, and the results are good for 2 to 3 weeks. But the problem of epilation is the follicular keratosis or folliculitis or infection or inflammation. And it's painful too. Now, depilation is done with depilatory creams. Now, these creams are applied on the skin in the Hirschsprung areas, and they actually break the disulfide bonds which are present in the hair. So the hair disintegrates and can be swiped away. But again, this method is also not with much satisfactory results because the hairs would come out again in 2 to 3 weeks. And it also holds the side effects of folliculitis, inflammation, irritation, contact dermatitis. A woman might be even allergic to that particular depilatory cream. Bleaching is not a method of hair removal, but definitely if bleach is applied over a portion of the hair would become lighter, and therefore it will not be so very much prominent. So these are the temporary methods, but they do not have much satisfactory outcomes. They're only for temporary 2 to 3 weeks or max to max 4 weeks. Permanent methods of removal of hair are by laser or electrolysis. Laser has come up in a big way for the removal of the hair in Hirschsprung's woman. It is a non-invasive method, but here the heat as well as the energy is applied to the hair bulb so that the follicular epithelia is destroyed for the momentum. And this laser has to be repeated. It is done at 4 to 6 weeks interval. About 5 to 6 sittings are needed, and the patient might need a touch-up therapy at 6 to 12 months. That is Every year, she might need a touch-up therapy with a laser. The laser which are available are good for the fair-skinned people because they cause pigmentation. But only the ND-YAG laser which is available, that is good for the black-skinned people. Otherwise, laser might also lead to pigmentation in some. Electrolysis is the only permanent method of hair removal in Hirschsprung woman, but there are disadvantages with it. Here, we apply electric current to the hair follicle and destroy the hair follicle. That's the reason why electrolysis is permanent, because it destroys the hair follicle and hair will not come out with that hair follicle ever. But it's painful, it causes irritation, it might even cause inflammation. There has been a big randomized controls trial, a comparative trial between laser and electrolysis. And though laser is not as effective as electrolysis, but still the women were found to favor laser than electrolysis because of the side effects which are associated with electrolysis. The second aesthetic concern is acne, which is found in 10 to 34% in the PCOS woman. Here also, androgen excess. That leads to increased sebum production, increased growth and secretory function of the sebaceous glands. And thus, increased amount of sebum forms the condoms. The condoms then get secondarily infected with Propionibacterium acnes. And that results in subsequent inflammation, pain, reddening, irritation, and also cosmetic concerns. And this androgen responding sites for acne are obviously face, neck, front of the chest, and the back, upper back. Here also we need to evaluate if a woman compliance of a very rapid onset of progression, rapid onset and a very rapid progression of acne, definitely we must look forward to see that whether she is having any tumor of the adrenal or any androgen producing tumor of the ovary. Secondly, the menstrual history must also be taken. And third, we must also find out whether she is taking any medication which is increasing sebum production and also increasing the formation of acne. The common tests are the same. I discussed all the tests while I discussed hirsutism. The tests are all the same, but obviously in case of acne, until and unless it's very severe, we do not go for these common tests. We do it definitely when we suspect a very rapid progression of acne. Treatment is systemic or topical. The goals of the treatment would be to reduce the sebum production, clear the condoms, reduce the bacterial colonization, that is, reduce the infection, and that obviously is going to reduce the inflammation. The first line is obviously OCPs, and those OCPs, obviously, where the progesterone would be a cyproterone acetate or a drospirenone. Second line of drug is oral anti-androgens, but these anti-androgens are more commonly used for Hirschsprung than acne. Moreover, we should keep in mind that if we are using drospirenone in the OCPs, we should not be combining spironolactone with it. Or even if we combine, we should be monitoring the potassium levels because both are potassium spared. Third is oral antibiotics because condoms they get infected, and doxycycline, that is a tetracycline group of drugs, are the best ones here, but this have to be given for longer periods. One cannot give doxycycline only for 10 days or 5 days for severe acne. We need to give it often for 5 to 6 months. So when you give antibiotics for a longer period, the patients come back with candidiasis or with diarrhea. That has to be kept in mind. So often what is done is we give it for a short span, and as soon as the acne starts reducing under the action of OCPs, we stop the antibiotic. The other oral drugs which are available are the isotretinoins or the vitamin A derivatives, but these are very hepatotoxic often, and they cause peeling and irritation of the skin, peeling of the skin of the palms and the soles, and that's why they are not very popular. So oral pharmacotherapy, the OCPs, with anti-androgenic type of progesterone or the progesterone with low androgen index are the drugs of choice. Topical therapy, we have the retinoid cream. These are very comedolytic. The retinoid creams, they do not decrease the sebum much, but what they do is they break down the condoms so that the secondary infection goes down. And there is a benzoyl peroxide cream available, which has got a potent antibacterial action. So this is also not going to decrease the androgen axis, but definitely it's going to cut down the rate of infection and inflammation. And antibiotic creams are also available, like tetracycline cream, clindamycin cream, even erythromycin creams are available in certain countries, which can be applied to reduce the infection and the subsequent inflammation. Come to the third important concern, that is the androgenetic alopecia. Now, eccentricity here is again excess androgen, but this here androgen in the hair, I mean the scalp, that causes disruption of the proper androgen signaling. Here, there is a decreased proliferation of the follicular epithelia and progressive miniaturization of the terminal hairs. So there is a shortening of the anagen phase. This is the opposite which happens in Hirsutism. When androgens act over this androgen-dependent areas of the body, like in the beard area, in the moustache area, they increase the hair growth, because they increase the anagen phase of the hair. Whereas when this androgens, they act on the scalp area, they shorten the anagen phase or the growth phase of the hair. That is why the hair becomes shorter, thinner, and is characteristically this alopecia affects the top of the head. There is a vertex of the head or the front portion of the head, leaving behind the back and the side hair intact. Evaluation is same about the rapidity of the progression, have a menstrual history also, find out whether she has got a stress. A stress also might cause a androgenic alopecia, and if she is taking any other medication. Female hair loss has a scale to measure. There are 3 stages of hair loss. Stage 1 indicates minimal thinning that isn't easily noticeable. This is stage 1 diagram. As you can see, that only the part in the middle has thinned. The other portions are almost intact. And obviously, without telling, you cannot say also that she is having alopecia. Second one is the pronounced widening of the part and visible scalp. So now, if you see this picture, which is in the middle, you can see that there is a pronounced thinning out of the hair, and the parting of the hair is now becoming more broader. And third one involves severe hair loss with a visible scalp and potential baldness at the top of the head. And as you can see, that the baldness has affected the top of the head, that is the vertex of the head and the frontal area of the scalp. But the frontal line of the hair, that is receding. The alopecia starts at least 1 to 3 centimeters behind the frontal line. And the side hair is almost intact and the back hair is also unaffected. So androgenic alopecia is non-scarring. The hair follicle is not destroyed. That is why it has got a scope of treatment. Tests are the same, which we do for any androgen excess. Only difference is, since premenopausal women also have a higher level of testosterone, and they also tend to have a hair loss because of the high levels of testosterone. If the woman is premenopausal age, then obviously an FSH, LH, or estradiol needs to be done to confirm her premenopausal status. Here also the treatment is either systemic or local. Systemic therapy is usually done with finasteride, but truly speaking, androgenic alopecia does not have a very robust evidence of systemic therapy. The evidence is very limited and data is conflicting. Mostly what we do is the local therapy. Minoxidil is a very effective agent, either in 2% or in 5%, but 5% solution has been found to be more effective. It increases the duration of the anagen phase by enlarging the suboptimal follicles by acting through nitric oxide. But long-term use is needed and daily use is needed. What has been seen is the woman has been using for 2-3 months, the hair growth is nice, but the moment she stops, there is a relapse of the alopecia. This has got a side effect, contact dermatitis. So the woman who developed contact dermatitis following minoxidil, they cannot be put on minoxidil for a longer time. And the only cosmetic way of restoring hair is the hair transplant, which is done by the plastic surgeons. That's not our domain, using follicular units. But the problem is that this woman have got a hair transplant from the back of the hair because the reservoir is in the back of the hair. Now they would transplant the hair in the front, but the non-transplanted hairs would fall again. And that is why it is not one-time procedure. The person might require repeated hair transplants. And lastly, coming to the acanthosis nigricans, which forms a thick, velvety, hyperpigmented plaques, intertriginous areas, mostly flexion of the birds. It's a very important, particularly if the girl is fair, it definitely becomes a matter of concern. And what we do here, we give topical retinoids or chemical peels. Peels are new kids on the block, and this is being used in cosmetic, in a number of dermatology, in cosmetic gynecology. These are trichloroacetic acid peels or glycolic acid peels. Basically, they taking away the epidermis, and the new epidermis would come up later, which would restore or rejuvenate the skin. Insulin sensitizing agents have also been tried, but as I say, that these nutraceuticals, they're expensive and there is not much of evidence about their use as compared to metformin. And last but not the least, be it irregular periods, be it fertility, be it aesthetic concern, the key role of lifestyle modification in the management of PCOS cannot be overemphasized. So coming to the takeaway points, PCOS is most common endocrine disorder in the reproductive age woman. Dermatological manifestations are attributed to the androgen excess because hyperinsulinemia leads to hyperandrogenemia. COCP and anti-androgen agents are commonly used as the treatments, as the pharmacotherapy and cosmetic therapies in case of those who cannot tolerate or are non-responsive to the hormonal treatments. Thank you very much for a patient hearing.
Thank you, ma'am, for a very enlightening talk and covering almost all the aspects of the aesthetic part of PCOS. I request Dr. Hafizur, sir, to please give his concluding remarks.
Yeah. Good evening, everyone. Thank you, Dr. Monica. I think Savanti madam has very exhaustively covered one very important aspect that is not often discussed, that is on the cosmetic aspect of PCOS. And many times the patient actually also comes to see the clinician, but they actually don't express, but simultaneously they are also concerned about it. So I am sure this as having giving this elaborate aspects on this will have definitely impact on our knowledge as well as in managing and the different condition which actually many of the young girls are having problem with their cosmetic appearance. And once the things along with the treatment, Sevanti, by the way, I had mentioned that is the lifestyle aspect, which actually many of the things takes its own correction also. So I think it is very informative and elaborative talk, and it will definitely give the insights for management of the different issues, especially the cosmetic aspects on this. Thank you so much. And I'd like to thank you, Dr. Monica, and the PSC chairperson, Dr. Priyanka Roy, for giving me this opportunity. I think I'm sure this is an wonderful the PSC initiative on having different aspects, as well as the committee is doing excellent work. Thank you so much for giving me the opportunity.
Thank you.
Over to you, Dr. Monica.
Thank you, Monica.
Amitava, sir, for your comments. Sir, are you there?
Yes, yes.
Yes, sir.
Hello, am I audible? Hello?
Yes, sir, you're audible.
Yeah, yeah.
Thank you, Sevanti, for your great presentation. It is a great presentation by you on aesthetic aspects of the polycystic ovarian syndrome, and you have covered all the aspects, particularly the disfigurement of adolescent PCOS, especially acne, hirsutism, Heron syndrome, etc., etc. And you have clearly demonstrated all the treatment, because it is written not in books clearly, but you have demonstrated it clearly that which time, at which level we will have to go for treatment, because this is the common problem. Most of the patient comes to us with such a problem, and we are unable to treat because we send the patient to skin department. Okay. So thank you, Dr. Sevanti, for your deliberate and nice presentation. And if you have any questions, please ask.
Thank you, Amitava, sir, and thank you, Hafizur, sir, for chairing this session. Thank you, Sevanti, ma'am, for an excellent talk. And we covered two important topics of polycystic ovaries. One is the aesthetic aspect, and second is the oral ovulogence. Thank you, both our speakers, for today's session. We now move forward to our academic session number 3, that is the panel discussion. Our moderators for today are Dr. Indrani Roy, madam, and Dr. Satabdi Dey. And our expert for today, Dr. Meena Samant, madam. Before I hand over to Dr. Shatabdi for introduction of everybody, I would also like to inform that we have more than 270 people who have joined us for this webinar today. Thank you so much. Just because of all the esteemed faculty members and the academic content that people join in for these webinars. Over to you, Dr. Shatabdi, for the introduction of the moderators and the panelists.
A very good evening to everyone. Am I audible, Monica?
Yes, Shatabdi.
Yeah. A very good evening to everyone. Those were two very wonderful lectures. Thank you, Monica. Me and Indrani ma'am will be conducting a panel today on particularly around the management of polycystic ovarian syndrome across various ages. We will not only discuss the reproductive age group, but we will discuss it across various ages. So my co-moderator for today is Dr. Indrani Roy ma'am. Ma'am is a senior consultant and HOD at Nazareth Hospital, Shillong. She has been the president of Shillong Obsgynae Society, as well as the organizing chairperson of East Zone Yuva Fogsi, as well as National Yuva IAGE. And she is the member of breast committee, and she is also a DNB teacher. A very, very dynamic personality. Welcome, ma'am. I'm
Thank you
looking
so
forward
much.
to conducting the session with you.
Thank you
And
so much.
I am Dr. Shatabdi. I will be co-moderating the session with her. Our expert for the session is Dr. Meena Samant, ma'am. Ma'am is a senior consultant and HOD of Obsgynae at Kurji Holy Family Hospital at Patna. She is also the current president of the Patna OBGY Society, as well as the governing council member of ICOG. Welcome, ma'am. We have 9 very dynamic panelists with us today. Firstly is Dr. Nidhi. Dr. Nidhi is one of my colleagues. She is a consultant at Nova Fertility at Patna. She is a very, very dynamic personality. She is very much into academics. She has various awards to her credit. Welcome, Dr. Nidhi. Our next panelist is Dr. Shweta Lal, ma'am. Ma'am is currently the assistant professor and head of department at SBMCH at Hazaribagh. She is the member of various organizations. She also has various awards to her credit and various publications. Welcome, Dr. Shweta. Our next panelist is again my colleague, Dr. Isha. She is a consultant at Nova IVF Fertility Shiliguri. She has a fellowship in reproductive medicine. Welcome, Dr. Isha. Our next panelist is Dr. Gayatri. I think Gayatri's son is not well. She would not be able to join with us. She is a consultant fertility specialist and laparoscopic surgeon at Oasis Fertility Bhubaneswar. She will try to join. So welcome, Dr. Gayatri. Our next panelist is Dr. Simi. Dr. Simi is the director and chief fertility consultant at Holistic Fertility Care. And she is also the senior consultant and co-founder and managing director of Hope IVF. She is again another very active person academically as well as professionally. Welcome, Dr. Simi. So happy to have you here. Our next panelist is Dr. Polomi. Dr. Polomi is one of our younger brigades. She is a gynecologics and endoscopic surgeon at Marina Medical Center, Jalpaiguri, West Bengal. She has various fellowships to her credit, as well as she has been the organizing committee member of Endogyne 2024, Endo Kochi 2023, as well as Suffolk 2018. Welcome, Dr. Polomi. Our next panelist is Dr. Bandana Pradhan. Dr. Bandana Pradhan is a consultant fertility specialist and managing director at Noble Stride Fertility and Diagnostic Center at Sikkim. She has obtained the gold medal in Obsgynae from RIMS. She is also a consultant in Obsgynae and fertility consultant at STNM Hospital, Gangtok. Welcome, Dr. Bandana. Our next panelist is Dr. Mriganko Moli Shaha. Dr. Mriganka sir is the president of Kalyani Obsgynae Society, as well as an assistant professor in obstetrics and gynecology. He has been the Fogsi Kamini Rao orator as well as associate member of RCOG UK. Welcome, Dr. Mriganka. Last but not the least, our final panelist is Dr. Shraddha Chakiyar. Madam is an infertility specialist and consultant obstetrician and gynecologist at Shraddha IVF and Maternity at Patna. She also is the executive member of ISOPARB of the Patna chapter. She has fellowships, various fellowships to her credit. Welcome, Dr. Shraddha. Over to you, Indrani ma'am. I think we can start from here. A very warm welcome to everyone once again. Yes, I will share. Just a second, ma'am.
In the meantime, let me thank Dr. Monica and Dr. Priyankur for giving this opportunity today. Wonderful lectures we had now, and really beneficial, and I think we'll go ahead with the panel discussion now, and I welcome all the esteemed panelists today. We'll have all request everyone to be very short and crisp with their answers. Okay, so we all know, polycystic ovarian syndrome, it is an enigma, as we say, and it's the most common disorder, but it's yet to be seen as the most neglected endocrinologic conditions. And as we know, the incidence, it's around 20%. And there's some audio disturbance. Okay. And it is mostly affects the women in the reproductive age group. And if you see in every, 1 in 10 you will get. So if you're in OPD patients, if you're seeing at least your OPDs are filled with these PCOS patients, and 2 in 10 adolescents, and the incidence is rising in the adolescent population as of now, as we see in our day-to-day practice. So it is in the rise. Why is the incidence of PCOS rising? There are a lot of factors, mostly you see a lot of environmental factors, pollution. The people are more busy with their indoor lifestyle. The previous years before it was more of outdoor activities. Now there's a lifestyle changing. And as a result, we see that the increase in PCOS. Next slide, please.
Yeah.
So we come to the case discussion now. Now, this is a case one. She's a 13-year-old girl and she reports with her mother to your OPD clinic. And the mother is very apprehensive about the daughter who's presenting with irregular cycles. She is post-menarche, just 9 months. She's into menarche and her cycles are a little prolonged. It lasts for 45 to 60 days. And now she's presented into the clinic with a 50-day history of amenorrhea. Her BMI is 26. She has mild acne in the face and there is no other medical or surgical problems. And as nowadays everybody does, they come with already an ultrasound report and they'll tell you, this is my diagnosis. So this mother was no less than that. She also had an ultrasound done for her daughter, and then there were multiple follicles in both the ovaries. The uterus was normal size and shape, and she was worried about this. So now, what will be the diagnosis in such a case? So, doctor, can we have the first panelist, Dr. Nidhi? So, what will be your diagnosis, Dr. Nidhi, in such a case?
Yeah, so good evening to everybody. So hearing the case that you said, she's a young female, and it has not been even a year since she had a menarche. So I think that's a normal process, normal body cycle phenomenon, and it's just an initially menarche stage where the cycles have just started and it is irregular.
And any other investigations, very correctly said, because she's just into her menarche, so we will just immediately, we will not jump into the diagnosis. So any other investigations would you like to do to corroborate what you are saying now? Any other investigations?
Yeah, at this age group, I would like to do a basal hormone tests like FSH, LH, and for diagnosis of certain symptoms like acne or something. So we can testosterone and a DHEA as well. And apart from that, we can get a routine test done like the CBC for
Okay, so you will do her routine test, and definitely I think we will go for any metabolic syndrome we should rule out early, so we can do a OGTT and the FSH LH ratio. Now here, can the next panelist, Dr. Shweta, are you there? So can you just define what are irregular cycles? How do you define, what is the definition of irregular cycles? Dr. Shweta is there? I think if she's not here, then Dr. Isha, are you there?
Yes, ma'am. Yes, ma'am.
Yeah. So could you just give us an idea about how do you define irregular cycles?
Ma'am, so in this case, since she's a young adolescent female, just postmenarche, so usually it takes around 1 to 3 years to normalize the actual cycles in this case. So supposedly if she is post-menarchal 1 year and a cycle are more than 90 days, so you can say it's an abnormal. And if it's from 1 to 3 years, if the cycle duration is less than 21 or more than 45, it can be said normal. And if it's also more than 3 years and still her cycles are not regular, like if it is less than 21 days, more than 35 days, or if she's having less than 8 menses in a year, then it is said to be irregular. Otherwise, we can just tell her ki it may take time for her cycle to get normalized within 1 to 3 years.
Absolutely, because when you start menarche, the hypothalamo-pituitary axis is immature, so it takes around 3 years to get into the normal cycle. So that is how she can present with such. Now, can we have the next panelist, Dr. Gayatri, if she's not here? I think she's not here. Dr. Simi, are you there? So you're there. So in such a case, how would you like to counsel the mother? You have to really counsel her well. So how do you go about this counseling to convince her that she's just into the starting of menarche and irregular cycles? So Dr. Simi, right? Dr. Simi, yeah.
Ma'am, as Dr. Issa has rightly explained, what is the normal menstrual cycle pattern during early menarchal period. So definitely, when such with the such problem, girl will come with her mother. I would like to explain the thing what happens during early menarche. And she must be like I must be explain her ki that the days from 21 to 45 days still doesn't matter, and the number of pads, if she is using 3 to 6, it doesn't matter until and unless there is like producing anemia and all kind, and she will be counseled about like this, and definitely she will be counseled for the cervical cancer vaccination, HPV vaccination, and the general taking care of, and for the evaluation of the some hormonal profile like thyroid and prolactins, yeah, she is having any abnormality of these two.
Yeah, so I think you'll have to stress really hard on the counseling because the mother is really tensed up with her daughter, and you'll have to give a detailed idea about what is going on now and what could be the outcome. And of course, as you have said, I'm very happy that this is an opportunity for an HPV vaccine counseling. So definitely you are going to counsel. That's great. And of course, if she's as her BMI, you said it's a little bit, I said, not 26. So you have to counsel her regarding the obesity, which might in the future time, if she's not taking care now, that might lead to what other problems of obesity, and there might be mood swings. Those also have to be taken care of. Now can you next panelist, Dr.
Shraddha is there, ma'am.
Dr. Shraddha, are you there, Dr. Shraddha? Okay, so can you tell me why is this diagnosis of PCOS difficult in adolescence? What is the challenge for diagnosing PCOS in adolescents?
The HPO axis is not developed. So there may be multiple follicles. So based on the ultrasound, if we go, we should not diagnose based on ultrasound that she has, based on multiple follicles that she has PCOS. Actually, there should be at least 8 years after the menarche that we should diagnose her as PCOS.
Yeah.
So that is the thing. And we should be cautious before for diagnosing PCOS in a young adolescent.
Yeah. So as we see, most of these young girls, they come to your OPD and they have a little bit of irregular cycles. So we have to counsel that the hypothalamo-pituitary ovarian axis is immature now. So she'll slowly try to get settled down in the next 2-3 years. And you don't have to jump into giving her aggressive treatment for that. Counseling is the key cornerstone here. And a little bit of acne might be common in young adolescent girls. So any patient, because these are the mothers who will come with your OPD with an ultrasound report which says, and in the ultrasound report it will definitely be written this word, no, PCOS. So once they see that PCOS, they're so worried. So you have to tell them that just follicles in the ovary doesn't mean that your daughter is having PCOS.
The ultrasound should not be used for the diagnosis of PCOS
absolutely.
in an adolescent, and until and unless she is at least 8 years post-menarche.
Absolutely, that is the message.
And there are other aspects of PCOD that we should look, and that should be taken into consideration during counseling.
So, and just an ultrasound should be not used into a diagnosis of PCOS. So, is there?
I would just like to add that PCOS nowadays, I think, because of the ultrasound findings, it's becoming very overdiagnosed.
Yes.
We often get young girls coming with a USG report suggestive of PCOS, and then they will Google it up and they will all come tense, the parents and the child. So it's very important for us to reassure the parent that only an ultrasound feature suggestive of a polycystic morphology does not mean that the girl has PCOS, because I think it is getting overdiagnosed by the day. And every day, every second girl who comes to us with irregular menses just after menarche will have a diagnosis of an ultrasound telling that it's PCOS. So then I think we have to be very cautious and counsel them very
Yeah.
nicely.
And you should tell them that this is a normal pubertal transition.
Absolutely.
As we counsel for menopause, similarly, as you know, there's a transition. She's a young girl, now she's going into puberty. So this is a normal transition of puberty. And she's come for a routine health checkup. Check whether she's having anemia. If she's having anemia, rule out anemia, give her iron correction. Then stress upon lifestyle. If she's having a sedentary lifestyle, tell her that a little bit of regular exercise, stress on the diet, that nowadays the children are into junk food, so try and give them a healthy diet option, and of course nutrition and HPV vaccination. So these are the things which should be counseled to the mother. Okay, so I think we can go to the second case, Dr. Satabdi.
Yeah.
You can take over the second
So
case.
just ma'am, if you could just summarize the first case.
Yeah, so it's like that in such a case, it is a normal transition. That is what we need to counsel, because this is a normal puberty. She's just attained menarche, so it's a normal transition. And that's what I said, a routine general checkup, rule out anemia, and then a regular diet and exercise plan should be explained, so that in future, even if she has a tendency for PCOS, if she's on her toes from the beginning, then she gets into the habit of that lifestyle, because this is the most important. Avoid prolonged screen time, go out for regular walks and exercise, and of course HPV vaccination can be stressed on the mother. For the mother, pap smear testing, and for the daughter, HPV vaccination. I think that should be the message for such young girls who come with their mother to your OPD.
Thank you, ma'am. We'll very nicely discuss short crisp answers. The second case, now she is a 17-year-old girl, a class 11 student. She presented with frequent cycles since the past 6 months after she had joined a coaching class. Now her flow lasts for around 5 days and the cycle length varies from 15 to 18 days. She had menarche 5 years back. There is no history of acne or hirsutism. However, there is a history of weight gain around 3 kg in the last 2 months. Thyroid parameters are normal. Her body mass index is 26. There is no clinical evidence of hyperandrogenemia. On investigations, her TSH is 4.2. Her prolactin, FSH, LH, and testosterone are all normal. Her 75 gram 2 hours blood sugar levels are also normal. So I think Dr. Polomi, what do you think is the probable diagnosis over here, and what investigations are you going to advise for her, and how are you going to counsel her? If you could take this.
Good evening, everyone. Am I audible?
Yes,
Dolly, please go on. Yes.
Yes. Since the hormone report says the hormone levels are normal, so the patient is at risk of PCOD. She doesn't have proper PCOD yet. And as for investigations, we have to go through the same investigations as discussed previously. That is LH, FSH, LH ratio, and TSH, prolactin, and testosterone levels, DHEAs. All these routine investigations for PCOD have to be run.
Yes. So the take-home point over here is that we tend to associate PCO with oligomenorrhea, rather longer cycles, amenorrhea and oligomenorrhea. But such females who are at risk of PCOS, as rightly suggested by Dr. Polomi, these might have irregular cycles in the form of short cycles. They might have short cycles, but since there is an obesity present, there is rather the BMI is little high. So these are the ones which are at risk of PCOS. So we have to follow these females through their adulthood. Now, how are you going to counsel her? And does she need any follow-up? When will you follow her up, Polomi?
Yes, of course, she needs follow-up. 3 years post menarche, if any patient complains of such thing, they have to be followed up. And the patient and her relative, maybe her mother, have to be counseled that she hasn't gone into PCOD yet, and she has to lose some weight, and she has to do some lifestyle changes, maybe dietary changes, and re-evaluation is must for these patients.
Absolutely. Rightly said. If menstrual irregularity is the only complaint, then she has to be followed up at 3 years post menarche before diagnosing her as PCOS. Now she is only at risk of PCOS. And when in relation to the polycystic morphology on the ultrasound, like we were previously discussing in the previous case, if ultrasound finding of a polycystic morphology of ovaries is the only finding in this girl, then we have to wait for at least 8 years post menarche before saying that she is a case of polycystic ovaries. Only an ultrasound is not sufficient to call this girl as a PCO girl. So, of course, as rightly said, lifestyle modifications are very, very important. The first therapeutic recommendation in any age group is whether she is at of PCOS or she is a case of PCOS. Lifestyle modification is very, very important. Diet, exercise, her sleep has to be good. Of course, psychological support if required for anxiety is very important. Dr. Nidhi, throw some light on what all exercise she can do, how much she in controlling adolescent PCOS?
Yeah, so exercise is the first and the foremost step and the most important intervention that has to be done for a patient with PCOS or at risk of PCOS. So we must recommend her that you should have at least half an hour of strong exercises per day. If not, then you can do a brisk walking or a jogging for at least half. We say that at least 4 times a week. And we should have small lifestyle changes which can be easily made, like any effort which increases our physical strength. Like we should take the stairs instead of lifts or escalators. And we should walk if it's a nearby place. We should prefer to walk over there rather than opting for a two-wheeler or a four-wheeler. And we should try at every level to increase our activity. Like even while talking over mobile, we should walk during that time. So these are some small steps which for lifestyle modifications in exercise.
Absolutely. Yeah. Our counseling of the mother is very important. We have to explain the mother and the girl that with exercise, you are not going to lose weight overnight. No one is advising you to lose weight overnight. It's a gradual process, and we have to explain them at least even 3 to 5% of weight loss is very, very significant. Whatever small weight that you lose, even that is very, very significant, and it is very, very helpful in making her cycles regular. So this has to be counseled to the mother and the girl that it's not going to happen overnight. They often then maybe they will fast or they will undergo some crash dieting and all. That all is not required. Proper exercise with dieting is very, very important. So it has to be a balanced diet and proper good exercise, as very nicely said by Nidhi. So again, we know that diet for all it has to low calorie, low carbohydrate, low fat, high protein, no junk food. If you are wanting to lose weight and if you are wanting to take care of your PCO, you have to avoid junk food. Okay, so that was about it. I would just like to say 3 points as management. In the management, we discussed the management of PCO in adolescent girls as well as at-risk adolescent girls. Here we should have 3 very main treatment goals. I forgot to include the slide. I will just tell you all the 3-4 points that we have to keep in mind. What should be our main treatment goals in adolescent girls with PCO or those at risk of PCO? Protecting the endometrium from the risk of hyperplasia is very, very important. So the girl should bleed at least once in 3 months. So this has to be told to her. Even if she has to take medications, progesterone medication to get a withdrawal bleed, she should take it every 3 months. This will protect her endometrium from the risk of hyperplasia in the long term. Controlling menorrhagia is very, very important because often these adolescent girls with PCO will have oligomenorrhea followed by menorrhagia. So they tend to be anemic. So controlling menorrhagia is very, very important. Supplementing her with iron is very, very important. Of course, combined oral contraceptive pills are the most effective treatment. They take care of many things. If her BMI is on the higher side, of course, addition of metformin also helps in these girls. So these are the 3-4 key points that we should keep in mind while managing an adolescent girl who's either at risk for PCOS or who's already having PCOS. Over to you, ma'am. We'll move on to case 3.
Yeah. So we come to the next case now. Now, it's the same girl. Now, she comes and presents now to you after 10 years. She's now 27 years and she's into a very hectic job profile. She's almost working 12 to 14 hours. and she has followed the weight loss advice which we have given her. She's on her regular lifestyle modifications and her cycles are regular. But of late, she has again started to gain weight and her periods have again become irregular. Now she has complaints that her cycles are delayed by 2 months. Every month she's not getting, and whenever she gets her menses, the flow is slightly heavy. She's put on weight, her BMI has gone into 28. Then she's developed acne and also a little bit of hirsutism. She's seen her facial hair has increased in the upper lip and chin, and there are also some hairs in her lower abdomen. On investigation, her hormonal profiles are normal. Now she's married, 3 years into marriage, and she's planning her pregnancy, and she's very anxious to conceive because she's already known that she's into PCOS and that difficult in conception. So now, what will be the management in such a case? How are you going to tackle this patient? So now, can we have Dr. Bandana? I think she is not. She's here.
Yeah, Dr. Bandana, yes.
Yeah.
So, what are the issues? How are you going to manage this patient?
Okay, now practically speaking, when we see the the history that has been given, we see she's overweight. Okay, and right now, if she's having stress regarding her pregnancy, so obviously she'll be having a hormonal imbalance. She's having different issues like, so if she's having PCO, definitely she'll be having an insulin resistance also. So, firstly, what I would like to tell her is weight management, lifestyle changes, very important. First of all, lifestyle changes. It's no point taking stress. We would tell her to exercise, tell her to lose weight, very important. At least 5 to 10% of weight loss also helps in conception. Another thing, I think, if we are planning for conception, then we should think maybe regularize her menses for 1 or 2 cycles. After that, start her on ovulation induction so that she'll be able to ovulate properly. So yeah, for me, management will be firstly lifestyle changes in which her weight management is most important. Then secondly, her insulin resistance ke liye we can start her on metformin, okay, or iminostol. And another thing is, if she's planning for pregnancy, first of all, we'll try to regularize her menses maybe for 1 or 2 months, in which she has enough time to lose weight, and stress control, in which yoga can be incorporated, or exercise, meditation. If she's having cosmetic issues for hirsutism or acne, that can be dealt with. But if I think infertility is an issue, I think your lifestyle changes, weight management, and once she comes back to us with regular cycles, maybe for 1 or 2 months, then we will start her on ovulation induction with letrozole.
So before coming to that, how are you going to evaluate this patient? We'll come to the ovulation induction part later. So, what are the tests would you like to advise? Planning pregnancy, overweight, PCOS with irregular cycles. What are the investigations would you like to do?
Firstly, when the patient comes to us, we'll do a scan. Okay, we'll do a transvaginal sonography to identify whether she's really having PCO or not. Okay, if she has a typical polycystic pattern, we'll be doing her the hormonal profile like thyroid, serum prolactin, sugar, and her AMH. Okay, if it is corresponding or correlating with her PCO pattern on ultrasound, and we will be doing her tube test, basic HSG, to know whether her tube is also patent or not, because we cannot blame entirely on just the PCO that she's not able to conceive. And another very important factor is we cannot just leave out the male also. We have to have a proper evaluation of the male to find out whether even he's having some problem or not, because the blame cannot be shifted to just the female that she has PCO. She may be the one who's not able to conceive.
Yeah. So, and other than that, I think we should also do a prolactin level test because she's presenting with amenorrhea, and whether
thyroid, serum prolactin, and sugar.
Thyroid and prolactin, of course, we are going to do that. Then,
I think, madam has discussed hirsutism.
Yes, so we are going to skip the hirsutism management here because that was very detailed discussion by Dr. Shatabdi. So I don't think we will discuss that. Now, how do you correlate hyperandrogenism with insulin resistance? Who's the next? Anybody else who can do? Dr. Shraddha, are you there? You can take up this.
So actually, insulin resistance, there is an increase in the androgen level, and that is the culprit behind PCOD.
Yeah, the slide. Yeah, so it is
hyperinsulinemia. It decreases the sex hormone binding globulin.
Absolutely, yeah.
And as a result, because of this, the androgen, actually the sex hormone binding globulin, it binds the androgen. And so the free androgens are less. But because sex hormone binding globulin is less, the androgen level will increase, and that is the culprit behind PCOD.
We have decrease in the SHBG, which will cause decrease in the insulin-like growth factors, and that will lead to increased androgenic activity. That is why we are having the androgenic symptoms. Now, could you highlight a little bit on use of insulin sensitizers for this patient? Are you going to use an insulin sensitizer? Because
There is a role of insulin sensitizer in the treatment of PCOD, especially metformin. They are used, especially if the woman has high BMI. If she has metabolic syndromes, there is a role of metformin for treating PCOD. It can be started with 500 milligram dose, and the dose can be escalated to 2.5.
How far are you going to go? Up to metformin can be given up to
2.5 grams.
Yes, you start with a lower dose. Why do you start with a lower dose? Because it is seen that the GI side effects of metformin are there. So the patient needs a little bit of time for tolerance. So I start with 500 and then you go and escalate the dose. And most some mobile. Can we have the mobile off for somebody's phone is ringing? So and the one thing is that the advantage is that there is no decrease in blood glucose level. The patients it does not decrease the blood glucose level. So it is a good drug.
And if we can take an opinion from all the panelists that whether all of them routinely use metformin and metformin or no for all their PCO patients, or if they have any specific criteria in which they use metformin.
Who are the
take it from all the panelists
who are going to use metformin and
Dr. Simi, what do you do?
Yes,
Dr.
I
Simi, Dr.
use
Isha?
metformin and I use myoinositol too.
We'll come to myoinositol a little later. Now let's discuss about metformin first.
What about metformin?
I am happy with it. I have used many, and patients has like reported good with it, and I have seen the result. Basically, I have used this in infertility patients, basically PCO with an ovulatory cycle and willing for the issue, and I have got results. So I would recommend to use it and as a insulin sensitizer for the patients who are willing for.
Right, Dr. Isha, what do you use metformin regularly?
No, I do not give metformin regularly until and unless if there's any sign of diabetic or any kind of insulin resistance. I do not use frequently.
Is obesity a criteria? Do you use metformin for all obese PCO patients?
No, I do not use. And I don't think obesity is a criteria for using.
Anybody else has a difference in opinion here?
Yeah, Nidhi, what do you do?
Dr. Nidhi.
Hello? Yeah,
Commented.
Dr. Nidhi.
Yes, I metformin regularly and
regularly. Whether a lean PCO or an obese PCO, you use it for all?
Oh.
Yes. And Dr. Bandana, what is your opinion on metformin?
I do use metformin. I also correlate with the ultrasound findings. If I feel that they have a typical polycystic pattern when there's a lot of cyst, I feel that it works better. Start with a lower dose and then go higher.
Right, right. Do you encounter GI side effects very often?
Yeah, with metformin, GI side effect is horrible. So that's why when we started from a lower dose, at least they get used to metformin, and then we can increase if they're able to, tolerate the dose.
So that is why you start with the lower dose. But that means most of the panelists are here of the opinion that they're using it routinely, right?
Right. Ma'am, what about you, ma'am? What do you do for your patients?
I will not use it routinely, to be frank. For all patients, I'm not going to use. I'm going to see the profile of the patient. I think more of obese, and if she is having impaired glucose tolerance, then definitely I will use metformin. But for lean PCOS, metformin will not be my primary treatment. But if the patient is again planning pregnancy, those patients who are planning pregnancy, those patients definitely metformin has a role. Obese patients, impaired glucose intolerance,
in combination with the oral ovulations, yes.
Then
absolutely.
Metformin has
metformin in combination with the oral ovulations, I think, has a better effect on ovulation. So those who are planning pregnancy, definitely along with the oral ovulations.
Not as a routine, like just irregular cycles. She's not married and she's not.
In this case, she's 3 years post-marriage and she has come for pregnancy. That is why the panel answer is like that.
Maybe, but we are just asking whether you are using routinely or not.
If she is anxious to conceive, then it's okay. Otherwise, we don't routinely use it.
And coming to the next,
Right.
can we have an opinion about myoinositol now? Who will be
Yes.
Dr. Mriganko is not here,
So,
I suppose. Dr. Mriganko?
yeah, Dr. Mriganka, I think, is in a rally, ma'am. He was supposed to be
Oh,
in a
okay, okay.
rally. That's why he couldn't join.
So anybody, Dr. Isha or
Dr. Polomi, if you can take it. Dr.
Yes.
Polomi also has not
Okay.
answered
Yes,
in
ma'am.
some
Yeah,
time. Yeah.
Dr. Polomi, regarding myoinositols, can we have an opinion about myoinositols from you? Because these
Yes,
are the
ma'am.
things, this is the drug which everybody, all the pharmaceutical companies are promoting myoinositols left and right. So what
In
is
a
your
great
opinion?
way, promoting in a great way.
So
Hello.
Dr. Polomi, can we have your
Yes,
answer regarding?
it's a good insulin sensitizer, ma'am. It can be used regularly in all cases of PCOS, regardless of obesity or other patients, whether she's showing insulin resistance or not.
So I want an opinion about the panel regarding this myo, because metformin we have an opinion now, right? It is not as
Yes.
a routine. For myoinositols, what is the opinion of the house regarding myoinositol? There are two groups. There is myoinositol and D-chiroinositol, right?
Right. Ma'am, this is nowadays this is used in combination in 40:1 ratio. That is,
Yes.
it gives the optimum result.
So you're going to use in combination both myoinositol and
And
D-chiroinositol,
decarboxyl.
and combination works better. And I've seen here, as one of our panelists have seen, that you can use it routinely. Yes, because these are the patients who come to you and not talking about this patient. I'm just talking in general PCOS. Patient is coming irregular cycles. You're just talking on lifestyle modification. You get your weight loss. You health on the diet, and maybe it can be added, she'll have a psychological feeling, okay, I have a drug, and actually if it works, it has evidence that it works, so that gives her satisfaction also that she's on to certain drugs because we are prescribing her myoinositol. Any other difference of opinion? Anybody has any difference of opinion? So anybody using N-acetylcysteine? Any opinion on N-acetylcysteine? Yes, Dr. Isha, are you there, Dr. Isha?
Yes, ma'am.
Yeah.
Actually, these drugs, they all come in combination. So whenever it is so, then definitely we use it, because there's no as such a kind of any side effect. So as you said, it mentally satisfies the patient. And
Yeah.
usually it is said that N-acetylcysteine works in lean PCOS as
Okay.
accordingly.
So N-acetylcysteine, it is supposed to be a very powerful antioxidant, it is said, and
Mm.
it has activity on insulin secretion and in the pancreatic cell,
Mm.
and it has an anti-apoptotic effect. It has a preserves the vascular integrity. It is said that, but there is evidence says that the results are inconsistent for N-acetylcysteine. Though we have more evidence to support the myoinositols, for N-acetylcysteine, the efficacy shows inconsistent results. So now, in such cases, why are we concerned? What are the concerns for us? Yes, anybody? Dr. Gayatri, she's not here. Dr. Paulomi, Dr. Paulomi.
Yes, ma'am.
Yeah. So,
Uh,
can we have an idea about how does this obesity affect the PCOS? Why do we need to worry so much about the obesity in this PCOS? We're talking about this lady, this particular case. She has a BMI of 28, so she's in the obese category, and she's planning pregnancy. So, what are the obesity issues? Which do we need to treat the obesity, or how do you go about this obesity factor?
Ma'am, this obesity and PCOD and all these metabolic abnormalities, they are interlinked. So we need to get in control of the obesity to get better result in PCOD treatment.
So how does this obesity affect this PCOS? What
Uh,
happens in obesity? Because there is more visceral fat in obesity. So what will happen if there is more visceral fat?
more visceral fat means more androgens. And
Yeah, so
which
that
the
means there is
discussed.
decrease in the SHBG, that is the decrease in the sex hormone binding globulin. There will be increased insulin resistance, and as it results in more of hyperandrogenemia. So we need to take care of the obesity. So in such a case, who is planning pregnancy, what are the factors we are going to look into it? We are going to see the lifestyle modifications. We have to concentrate on her weight loss. So this weight loss should be like small targets. You just cannot say that overnight, as we have discussed. So it should be like small targets you have to give her that will cause her weight loss. Then stress on balanced diet. And for achieving ovulation, what is the ESHRE guidelines, which says what are the things we should do to achieve ovulation in a female with PCOS? One is metformin, which will manage the metabolic features. Then, of course, letrozole is the first line, and second line management would be with gonadotrophins. And
Next
if that
slide,
also
Abhishek.
fails, then we can go for IVF. So initially, it is ovulation induction with letrozole or clomiphene. Then we can go for gonadotrophins, and if that fails, then of course, if all other therapies fail, then you have to go for IVF.
There is role of laparoscopic ovarian drilling also.
And if you ask my opinion, as of today, there is no role of
Yes, ma'am,
laparoscopy.
I was going to tell that what is the opinion of the panel on laparoscopic ovarian
Definitely,
drilling. I have
we
not
are
moved to the
moving
slide.
back.
Strictly against laparoscopic
We are
ovarian
stepping behind, taking a step behind from laparoscopic drilling. But I have seen few patients who are undergoing laparoscopic drilling if they are not conceiving by themselves, but the dose required for ovulation induction after laparoscopic drilling is definitely less.
Yes.
The ovulation induction drug.
Ma'am, have you done laparoscopic drillings often?
Yeah, I'm
And
doing.
have you seen any additions or anything post the drilling, as it is said? I have not done any. I have only watched.
I have done, and some of them I saw that they are able to have their own ovulation by themselves. And recently, one of my patients, she conceived also.
And the additions and all was not there. There was no risk of any
That is
ovarian additions and all.
if we go for the second laparoscopy, then only. No?
Okay.
I would beg to differ here, because I think the evidence says that as of today, laparoscopic ovarian drilling was there a few years back, that was done left and right. But as of today, evidence says there is no role of laparoscopic ovarian drilling.
That is true, ma'am. Just can I speak, ma'am?
Yeah.
Yes, ma'am.
The first line is always weight reduction lifestyle. Next is clomiphene and letroz or plus metformin. Then is gonadotrophins. If still not able to conceive, we have to give the option of laparoscopic drilling or IVF, whatever. And some patients are conceiving, ma'am.
Maybe those patients might conceive, but if you're giving her an option of IVF, then obviously your laparoscopic ovarian drilling will cause more harm than good if the patient is planning an IVF. Anyway, this discussion can continue. I am just giving an what the evidence says regarding LOD.
Ma'am, I think laparoscopic ovarian drilling should be done by people who are good at doing it. Should not be tried by someone who's new, because then we might be over enthusiastic and lead to many end up decreasing the ovarian reserve in the process.
Yes.
So if at all it is done, it has to be done in a very precise way and in a very controlled way.
Yeah.
We cannot be over enthusiastic and do more. So that will do more harm than benefit.
Follow the guideline.
Absolutely, absolutely. Ma'am, if you could tell what do you do in a laparoscopic drilling, ma'am? The 4-point rule.
Yeah, 4-point. I don't do. I don't do laparoscopic.
There is 40. The voltage is 40 watt for 4 seconds, and fix that.
The rule of 4. It is the rule of 4.
Rule of 4. That
yes.
Okay. Because nowadays the laparoscopic drilling is not recommended actually. Okay, there might be difference of opinion. I am talking about what evidence is. So LOD has no role nowadays. Anyway, I think it is nice to have opinion of different panelists. No, if you are doing and if you've got good results, it's fine. Maybe
not good, but I am getting results.
In
because one
cases
patient she has conceived, and the others, those who were not ovulating, even with gonadotrophins, they are at least requiring less drugs, gonadotrophin, to ovulate. Those undergoing IUI.
Okay. So I think this sums up the third case, in this sort of patients, lifestyle modification. So initially every patient, lifestyle modification, give them small targets for weight loss. If she comes back to your OPD and she's not even lost 1 kg, just don't go wild. Why have you not lost weight? Even after 3 months, you're not even losing 1 kg. So you have to be patient with such patients. Give them the counseling that takes small weight gains. No, the targets should be small. For all the patients, don't give that, no, you are 15 kg overweight. right? So you need to reduce. So if you're 70 kg, you need to become 55 kg. So it should not be, you give them small targets for weight loss, concentrate on diet and little bit of other activities which will deviate her from the anxiousness that she's not conceiving. Put her into some other lifestyle modification, maybe a little bit of yoga, a little bit of whatever she likes to do, which will deviate her from the anxiousness, that will reduce the stress, which might help in conception. And then start with ovulation induction along with metformin. And if that fails, then step by step you go for gonadotrophins. And if not, everything fails, then you have to go for IVF. So I
And
think
just a hypothetical situation before we conclude the third case.
Yes.
How much weight loss should we wait for before going on for treating her? Rather, it's always a dicey situation. If an overweight female has come to me with PCOS and is anxious to conceive, should we keep on waiting for her to lose weight and then ask her to conceive, or should we immediately go for it? What is the opinion of the panel? Everyone can have an
Even the
opinion.
5
Dr.
to
Simi?
10%, 5
Yeah.
to 10% reduction of the weight can improve the fertility potential by 50 to 100%.
Yes.
So at least 5 to 10% weight loss we have to wait for. What anyone has anything different to do, or everyone is following the same thing? Nidhi, Polomi, Dr. Bandana, Dr. Isha?
It's always good to lose weight before conceiving. The outcome is good because of the
Yeah,
conceiving or
actually,
metastasis. Not just the outcome of conceiving, her pregnancy is also smooth. She has
Smoother,
less
yes.
obstetric complications.
Yes, very rightly said, because the
Very
obese
rightly
patient
said.
will have lot of obstetric complications. So regarding the waiting, it is important to see the age of the patient here and her, AMH count also, like how long we can wait. That is very important. What is the age
Her
factor?
married
Yeah.
life also. How long
Yeah.
has she been married
So
for?
these things to be taken into consideration of how long we are going to wait to give a better outcome. But definitely, obese pregnancy, these are challenges of pregnancy, obstetric challenges in obese pregnancy. So we need to keep that in
I
mind.
just want to say this.
I just wanted to say that see, it's very difficult to ask a patient to weight loss, and definitely she is not going to lose weight of 5 to 10% within the 3 months.
Yeah,
And if
right.
it's the age is progressing, and I think we should continue the treatment at the same time along with the same counseling, rather than asking her, "Ki, if you lose this much weight, then only we'll start the treatment." It's better we go with the process simultaneously.
True.
It can be decided depending upon at what stage of life she has come. If she is at early
Absolutely.
age, then it can be
Very true.
advised to lose her weight. And if she has come after 30, then definitely we should go for the treatment rather than to letting her wait for the reduction of weight and then go further.
I think the whole
Polomi, anything
patient has
different
to
you
be
want to
taken
say?
into account.
Polomi, you're doing the same thing?
I think weight reduction is an ongoing process along with the treatment.
Right. Yes, true. Bandana, Dr. Bandana? Since you
Yeah,
haven't...
I feel along with weight loss, we should see the duration of marriage, AMH, as ma'am has already told. So it should be an ongoing process. We shouldn't be stuck with just weight loss and then we will start the treatment, because that will cause more frustration to the patient. So
Yes.
we should do stepwise. We will tell her to do weight loss, and we'll start with, okay, we'll try something of this first line. If it doesn't work, we'll start with second line. So she has hope. It is very important to give her hope.
And many a time counseling really helps, to make
Yeah.
patients pregnant.
And as very rightly said by Dr. Simi, and at what point of life she has come to us is very important. At what stage of her life she has come to us. And of course, it's an ongoing process. It's easy to say that you lose 10% of your weight. So if she's 80 kg, she has to lose at least 8 kgs, which is a lot. So that might take months. So it's an ongoing process. We have to keep counseling her and keep continuing with our treatment as well. Okay, I think we'll move on to the next case, ma'am.
We'll move to the next.
Yeah, we'll come to our final case. We discussed PCOS, at-risk PCOS, adolescent PCOS, and the reproductive age group. A little bit discussion on a perimenopausal age group and PCO. So now we have case number 4, where we have a 42-year-old lady who complains of irregular or missed periods. She also has mood changes, thinning of hair on the head, excess hair growth on the face or body. She's also complaining of weight gain, and for the past 6 months to 1 year, she's also having depression. Now, is it only perimenopausal transition or PCO, and why we should evaluate and how should we evaluate? Nidhi, you have been quiet for some time. Where are you? Please take it. Yeah, why are we concerned? Is Nidhi there? or anyone can take it? कोई भी ले लीजिए, please.
Yes.
Simi, you can take it, yeah.
Yes, it's a age. She is 42 and she is having lots of feature which is indicating about atherosclerotic features too. So she should be taken care of properly and should be investigated properly and should be counseled accordingly. What is happening with her? She must not be left she is having the perimenopausal features and not cured.
Next slide, Abhishek, please.
Shatabdi, I wanted to add, see,
Yes, please.
42 years, she is going into a perimenopausal transition. Whatever the symptoms you have suggested, they may be present in these patients. But there are few things where you have highlighted that there is increased hair growth and all, which may not be the sign of perimenopausal transition. And regarding it, we can ask her history if she had some kind of PCOS features during her reproductive age. Depending on that, we can evaluate her.
So true. Very,
Metabolic
very rightly said. Yes. Next slide, Abhishek. Yes. So why are we concerned over here? We are concerned about the long-term consequences if she has been, as rightly said by Dr. Simi and Dr. Isha, that if she has been having PCO in the reproductive age group and it has continued into the perimenopausal age group, we cannot just ignore it saying that this is just perimenopausal transition. Considering her group of symptoms, this is very likely a PCO, and we have to be concerned because at her age, the metabolic consequences of PCO are going to be a lot more. There is around a 7-fold increase in atherosclerotic cardiovascular disease. There is an increased risk of type 2 diabetes mellitus and also an increased risk of arterial hypertension. So we have to keep these things in mind. These might not be as common in the younger age group, but these take great importance if a perimenopausal woman comes to us with PCO. So these are the 3-4 things that we have to be very careful about. We have to evaluate her properly, and accordingly we will have to guide her depending upon her symptoms. Next slide, Abhishek. So what is the link between this perimenopausal age group and PCO? Now both PCO and menopause, they involve change in the sex hormones, but the processes are different. However, once she's achieved menopause, the key features disappear, so we cannot diagnose PCO. Now, some research suggests that underlying changes persist into the later years. Like we just said, people with PCO may have a higher risk of metabolic syndrome after menopause than those without. Now, during menopause, a person may experience symptoms of both PCO and menopause, and some of these symptoms also overlap. As menopause approaches, periods become more regular for many people with PCO. After menopause, the inflammatory aspect of PCO still persists, and the risk of metabolic disease increases as people get older. If anyone of you could take it, what are the symptoms that overlap between perimenopause and PCO, and what are the symptoms that are likely to be different? Anyone? Dr. Shraddha, if you can take it. Yes. Next slide, Abhishek.
Oligomenoria, delayed period.
PCOS,
yeah, yes, ma'am.
The perimenopausal symptoms are that she has irregular cycles. She can have delayed cycles, scanty menses, and this symptom of menstrual irregularities is the same that of PCOS. But the symptoms which doesn't correlate will be hot flushes, mood changes,
the baldness or the depression what she is presenting in this case.
Next slide. Said by ma'am, the similar symptoms are irregular or missed periods, difficulty becoming pregnant, of course, mood changes, thinning of hair, weight gain, depression. Next slide, Abhishek. And the different symptoms which are more likely to occur with PCO include acne and darkening of the skin, and symptoms that are more typical of menopause are hot flashes and night sweats. So there are some overlapping symptoms, and there are some symptoms which are more likely to occur in PCO, and there are some symptoms that are more likely to occur in menopause. So of course the symptoms are overlapping like with adolescents, but we have to be careful, mindful, and treat her accordingly. Next slide, Abhishek. Yeah. So how will you manage PCO and menopause? Dr. Bandana, Dr. Polomi, if you could take it. How will you manage it? can be a little different from managing an adolescent and reproductive age group PCO? Dr. Bandana, yes.
Yeah. Mainly, we'll have to ask her to have a healthy lifestyle. That's very important. Eat healthy, lots of fruits and vegetables, avoid junk, sleep early, get up early. She can start exercising. That's another very important issue that has to be told to the patient. And use less of mobile phone, because right now I think most of the people using mobile phone, they'll be sleeping late, getting up in the morning as soon as they get up, because it causes a lot of stress also. And then in case they're having a lot of problem regarding their menses issues or any hormonal imbalance, we can also give them birth control pills to help them in reducing the problem that they may be facing.
So as rightly said by Dr. Bandana, we have to advise her to have a nice, full, healthy diet. We have to incorporate good training into her regular life. She has to get enough quality sleep, and she also has, if we can, if required, we might also give her birth control pills, diabetic medication, or hormonal therapy. Uh, okay, I think that was about it. One take-home message from everyone regarding managing PCO, say in the reproductive age group. Yes, from a one point. Polomi, we can start with you.
In reproductive age group, the main line of management should be weight control, lifestyle modification, followed by other symptomatic. And most important in this age group is psychological support.
Absolutely. Yes, Dr. Isha, any take-home message from you?
So, depending on what the patient wants, how she is troubled, whether she's planning to conceive or not, depending on that, we'll counsel regarding what is important is lifestyle management. Even if she's thin, also lifestyle management is very important, and we'll counsel her if she's planning for any kind of pregnancy. Then we'll help her, counsel her regarding the best approach.
True. Dr. Simi, anything you
Yes,
want to add?
I am also with
Just
the
to sum
favor
up
of
the whole thing, yes.
Yes, to change the lifestyle, to eat healthy, the whole grain should be in the meal. The sleep pattern should be like according to the biological clock, like early sleep and early riser. The habit should be there. Should be a daily habit of the exercise at least 30 minutes per day for at least 5 days in a week, and to have drink a lots of water. And as told by Dr. Vandana, very true. Because of the mobile, there is a lot of stress. So the main take home messages from my end to change the lifestyle and move ahead.
Absolutely. Shraddha ma'am?
Yeah, my take home message is also the same. That is the healthy lifestyle, daily exercise, eat healthy food, avoid junk food. And if you are, there should be cordial relationship between the husband and wife for the right time of intercourse.
Absolutely. Yes, Dr. Bandana, we'll end with you. And what is your take home message?
Yeah, when a person is having PCO, I think they should be counseled right in the beginning only when they come to us in during adolescent also, that they may be having difficulty in conception later in life. So so that they're mentally prepared, because we have seen that in this new era they are postponing their pregnancies, and later we realize that it's very difficult for them to get pregnant, and we cannot incorporate the lifestyle changes as has been earlier discussed, because if their age is very less, we cannot tell them lose weight and come back, because they may be already 38, 39. So it's very important to tell them and counsel them right in the beginning only, that these are things that you may be facing in long term. So when you get married, pregnancy planning is very important. Otherwise, I would also like to tell them that oocyte cryopreservation, embryo cryopreservation, these are things that are there in the latest technology, which can be used by them, even if they plan to get pregnant later. So, and another thing is, once they get married, the thing that we say, that if they're more than 35 years, they try normally for 6 months. If not, then visit a doctor. If they are less than 35 years, 30 or 35 years, then try for 1 year and then visit a doctor, so that the stress on the couple is less. They know that they have a problem and they should get counseling for it as early as possible, because the later they seek the treatment, the problem will be more profound.
Indrani ma'am, anything you want to add up?
Any patient coming to your OPD with me in whatever period she's coming, might be early adolescent, reproductive. I think the best thing is that you counsel the patient that PCOS is a disease, and whatever you treat, it's not that something I'm going to give you and it's going to disappear. You have to learn to live with PCOS. That is the thing you should tell her, that yes, I have the disease and I'm going to live with it. I'm going to take care of the problems which occurs every time at every phase of life. In adolescence, the problems will be different. In the reproductive age group, the problems will be different. In the perimenopausal age groups, because it will go on, the process, then the endometrial cancer, so many things, it is all related, starting from the adolescence to her menopause. So she has to be counseled that I have a disease and I have to live with the disease, make the best utility of it, and get a healthy and a balanced lifestyle, which will make me as confident as a woman. Though I have the disease, I can do anything with that. That should
Absolutely. Very, very rightly said. I would just like to add that psychological support is also very, very, very important, along with the lifestyle changes, weight loss, medications. In one thing that is common in all the age groups with PCOS is the psychological trauma, the body image issues that these females go through. They might have mood swings, they might have depression, and this might be a cause for it. So we have to be very careful while counseling the patient, give her a wholesome approach, give her a holistic approach, along with taking care of the metabolic and the other features, also take care of the psychological aspect. I think we can end with that. Thank you. Thank you. A very, very heartiest thanks to all the panelists for taking out your time and joining, for accepting our invitation. And thanks a lot, Indrani ma'am, for
thank you, Dr.
moderating.
Satabdi, Dr.
Thank
Monica, and all the esteemed, knowledgeable panelists for enlightening us today. I'm happy to be a part of this today.
Thank you. Over to you, Monica.
Thank you, Indrani ma'am, and thank you, Shatabdi, for moderating an excellent panel and getting the best from all the panelists for the very good take-home messages for all the delegates who have joined. I am extremely thankful to Foxi office bearers, Dr. Jaideep sir, Dr. Madhuri Patel madam, Dr. Parishit sir, for allowing us to conduct these series of webinars under the Public Awareness Committee. We are also grateful to our chairperson, Dr. Priyankur Roy, whose brainchild is this webinar, and I and Shatabdi usually coordinate. We also thank Dr. Rekha Jha madam and Dr. Indranil Datta as conveners for the program. I would like to thank all our chairpersons for today, Dr. Maushmi madam, Dr. Hafizur sir, Dr. Ritunath sir, and Dr. Amitabh Pal. Our faculties, Dr. Indrani Roy madam, Dr. Shatabdi, Dr. Sevanti Goswami madam, and Dr. Sujata Kar madam, who have painstakingly got the best of the academics for all the delegates. Last but not the least, all our panelists, Dr. Simi madam, Dr. Bandana ma'am, Dr. Shraddha, Dr. Paulami, Dr. Isha, for an excellent panel discussion. Thank you, Corona and Dr. Abhishek, for the technical help. Thank you, everyone. Good night.
Thank you all. Let's all keep praying that we
Bye-bye.
indeed achieve justice in Kolkata someday. Let's all keep
Yeah, we
praying for
support
that
that.
also. Let's all support that. Thank you all. Good night.
Thank you.
Good night.